So let us discuss about one more exam, this INSS 2025 November. There are a lot of questions and I don't feel much bouncers there, but in-depth questions were there. Some of them are actually very easy. So we will go in each system like we used to discuss. We will go with each system, how many questions asked. And we'll go to movement disorder and dementia. It combined both movement disorder and dementia into one module where it covered around 8 questions were there. First question was polycythemia is associated with which movement disorder is a question like chorea, tremors, Parkinsonism, and dystonia. So if you remember, I discussed in the main module, when I discussed the chorea, I told that chorea can be hemichorea or generalized chorea. Unlike in other movement disorder or in other systems where whenever you see a hemi or focal signs, you think of focal lesions. Here, I had told you specifically and I had shown this figure also. See, hemichorea, you think of hyperglycemia and polycythemia. These are two metabolic components which present with hemichorea. So this is something which I discussed, and forehead raising chorea is classic with Huntington's. All those things are in the module. So basically, the answer is polycythemia is associated with chorea. The movement disorder present polycythemia is actually chorea. So it improves with correction of polycythemia. So a phlebotomy and hydration actually prevents chorea in such conditions. So next question was which of the following statement regarding dystonia is false? And even if it looks a last question or lengthy question and lengthy options, this was fairly one of the easiest question. The first option is blepharospasm is not a dystonia. That itself is wrong. Blepharospasm is a dystonia. It's a type of dystonia which we have discussed in our module. I had shown the video also, I think, in our residential corner. Then second option, gestalt antagonist is classical for dystonia. Yeah, that is a sensory tricks which I have explained in detail in the module. So that is true. Then dystonia is defined as sustained or intermittent involuntary contraction of the muscles results in abnormal posturing or movement. That is actually the definition of dystonia. That is true. Mirror dystonia also I think I had mentioned. When suppose you have dystonia on right hand, right cam, you will tell the patient to write with the right hand and you will keep the hand like left hand like this. You will see the same dystonia happening on the other hand. So that is what is known as mirror dystonia. So that is also in fact true. So the wrong option in this is blepharospasm is not a dystonia, is wrong because blepharospasm in fact is a dystonia. Next question is PISA syndrome. PISA syndrome, you all know, I discussed in the module also. PISA syndrome is actually lateral bending of the body, that the trunk is known as PISA syndrome. And the anterior bending of the neck or lateral bending, we call it as collis, like torticollis, androcollis, retrocollis. The torticollis is not lateral collis, torticollis is actually rotational movement. And anterior bending is camptochromia. So the answer is lateral bending. I just want to add one more thing. Even the uter PISA syndrome is more suggestive of MSA. In fact, the numerical number PISA, like lateral bending, is much more common in PD or IPD, idiopathic Parkinson's, than MSA. Around 4 to 5% of MSA can have PISA like presentation, but IPD in the due course, not in the beginning. If you have in the beginning, it is MSA, but in the due course, after 5 years, 10 years, once the dystonia set in, IPD, around 8 to 9% will have PISA syndrome. Now coming to the next question, this was, I think, I had to again, like any other recall discussion, the questions is what we got from the students and we didn't get entire option. We tried to modify it, added few things to complete the sentence and all. So there will be some changes which is quite natural with any recall session. So which among the following is false about Alzheimer's was a question. Presenilin 1 is seen in chromosome number 7, presenilin 2 is seen in chromosome number 1, and ApoE4 is the most common cause of late onset Alzheimer's disease. So, in fact, there are the genetic Alzheimer's can be divided into early onset and late onset, which again we discussed in the module. And this time they ask about some conceptual things in like this pattern. So basically, presenilin 1 is there in chromosome number 14. Presenilin 2 is there. So the wrong option is presenilin 1 is there in chromosome number 7 is a wrong answer, even if you don't know other thing, but this is something which is very a factual thing. I personally doesn't like much of these factual genetic questions because this doesn't test anything rather than your memory. So early genes are APP gene, the most common is presenilin 1 again, followed by APP, then presenilin 2. Presenilin 1 in chromosome 14, presenilin 2 in chromosome 1. This is something which we have discussed in our module. So Precedent 1 is not in chromosome number 7, but it is in chromosome 14 is a wrong statement. Precedent 2 is in chromosome number 1, and ApoE4 is a most common gene. So late onset, 20% is related to ApoE4. Other genes also we have discussed. If you want to see in detail, you can go to the module on Alzheimer's where I discussed about the genetic thing. Next question is the correct match regarding GBS. This is also again one of the quite common question in DBS. Usually they ask which is a site of DBS. I'll just discuss a few things about DBS, about the FDA approved and non-FDA approved, but and which are not approved but used. So basically, Parkinson's it is GPI and STN. Parkinson's it is GPI and STN are a site, not globus pallidus interna. So that is wrong. Epilepsy, yeah, anterior nucleus of thalamus is site of stimulation in epilepsy. Dystonia again in globus pallidus is site, particular globus pallidus interna is a site. Depression, it is not subthalamic nucleus it is used, it is nucleus accumbens. So the true correct match is epilepsy is anterior nucleus of thalamus. If you remember the module, I have not discussed it, but I have discussed the recall sessions again in the previous sessions, and about this. I'll give you a few slides on this. You keep it for your future exams because this has become one area they're quite commonly repeatedly asking. So FDA approved site are Parkinson's is STN, which is the most common, followed by GPA, and essential tremor WIM nucleus of thalamus. This is very important, WIM nucleus of thalamus. And dystonia, it is globus pallidus internus. And other than movement disorder, that is what nowadays they are asking. One is obsessive compulsive disorder, anterior limb of internal capsule, nucleus accumbens and ventral striatum, and epilepsy, it is anterior nucleus of thalamus. That was the question asked here. And these are certain sites which are used in research purpose, which is not yet approved. But if questions come, this is not approved, because if they ask FDA approved site, you go with that. So major depression is subcallosal, cingulate, and nucleus accumbens. These are the major depression where they are attempting with DBS. And Tourette syndrome, it is thalamus, basically centromedia nucleus, GPA and anterior of internal capsule. And chronic pain, it is again another area where the periventricular gray and thalamus are subjected for DBS. Alzheimer's, this is again under research only, which is not yet approved, not yet practically using anywhere. And addiction, nucleus accumbens and the ventral striatum. This is a site of addiction. If you remember, I discussed about the reward pathway where I had mentioned all those things. What is nucleus accumbens? It is nothing but the anterior part of the caudate nucleus head. That is nucleus accumbens, that forms the nucleus accumbens. If you take caudate nucleus, a tadpole-like thing, the anterior part which forms the nucleus accumbens is again supplied by ACA. GPA DBS is used for trouble-from dyskinesias and mild cognitive behavioral disease. STN is used in cognitively intact dyskinesia, and STN is the most common site which is used for Parkinson's, and the best site is STN, epilepsy, anterior nucleus of thalamus. So these are the other indications of DBS. Just remember this question because this keep on asking nowadays in one of the exams, either in NEET or in INA. Then coming to the next question, which of the following is not the cause of rapidly progressive dementia? So rapidly progressive dementia, you know that rapidly progressive dementia, if you see, I had explained about rapidly progressive dementia. Some of the rapidly progressive dementia, classically the thing comes to your mind is vasculitis, and the second thing it should come to your mind is CJD. Like that, if you see, FTDs also can have a rapid progression. Paraneoplasty can have rapid progression. They can progress in months. Vascular dementia, sometimes, especially when stroke, it can have rapid progression. And among this, Friedreich's ataxia is something which usually doesn't present classically with dementia. So that is the probable answer here. Alzheimer's also is not classical, but sometimes, because the definition of a rapid progressive dementia is actually in the Bradley, it is 2 years. And practically what we take in some guidelines is 1 year. So that is not 6 months or 3 months that is considered. So that also comes under one among the DDs. Some of the variants of Alzheimer's can progress like that. So even if you think Alzheimer's classically comes under the dementia, you may think Alzheimer's is not a rapidly progressive dementia, but actually if you see the definition, by definition, it is progression of dementia. Even I have told the same thing in the module. It is given as 2 years, but some definition till 1 year. But you have some variants of Alzheimer's which can progress rapidly. And vascular dementia, particularly when you have multi-infarct, recurrent stroke happening over the period of 1 month, 2 months, they can present rapid progressive dementia. And paraneoplastic and autoimmune are classical vasculitis, paraneoplastic, autoimmune, fastly growing tumors. All these are classical examples for rapidly progressive dementia, and some of the FTDs also comes under this rapidly progressive dementia. So it doesn't mean degenerative is out. That is what I want to tell you. If you remember, you can go to dementia session where I had discussed about the table on rapidly progressive dementia. Now coming to serum markers of Alzheimer's disease is interesting because there are two entities like P181 and P217 which are serum markers, and A beta 42 and phosphorylated tau, these are CSF markers. These two entities are newer one, and even doing these serum markers are now available in India. Even in my place it is available. So that these things are there, but you have to spend a lot of money, like 10,000 to 15,000 for this test. And I still think that even if you do it, what are you going to gain in our scenario? Nothing. So once we have some specific therapeutics which we can use, then this became important. Till that, this is important for entrance. So remember, serum it is P181 and 217, and it is CSF, A beta 42 and phosphorylated tau. These are the markers which are used classically in Alzheimer's. So the answer is AP tau 181. It is not phosphorylated tau 237, it is 217. And A beta 42 is a confusing option here. A beta 42 is the CSF, and the question is regarding serum. Serum is P tau 181 and 217. The new Harrison and new also include this thing, I think. So, which sign is not seen in CJD is the next question. You know the classical signs of CJD, the Hockey stick sign, Pulvinar sign, cortical ribbon sign. This was in something which I discussed in the MCQ session. So, whenever you are going to see the marrow module, don't just see the theory part. I had given 10 or 12 in MCQ. That is there again in your theory part also it is there. The videos are there. I had covered autoimmune encephalitis, I had covered embryology, I had covered this prion as MCQ, and infections part 1 and 2 as in MCQ. Just go to the MCQ, that especially infections, prion disease and autoimmune encephalitis, because these three things will a lot of questions in INA. So especially even you, it may help you in the stage 2. So you must go through these things. So the shrimp sign, this was actually asked in the previous AIMS exam, which you have discussed. Shrimp sign is seen in PML, in the cerebellum, the hyperintensity which looks like shrimps. I have explained the previous discussion on May 2025 AIMS, the shrimp question game. So the CJD, the gist is not a classical sign of CJD, is shrimp sign. Then posterior cortical atrophy is a variant of posterior cortical atrophy is a variant of Alzheimer's. Again, we have discussed the same in the module. I had explained what are other causes of posterior cortical atrophy and what are the other variants of Alzheimer's: frontal variant, posterior cortical variant, corticobasilar variant, the classical Alzheimer's. All those things are different variants of Alzheimer's. It is not the variant of FTD. And posterior cortical variant again can also occur in certain other diseases like prions and all, and which we have exposed in the module. So there are 8 questions. And I felt there is one question which was phosphorylated tau 181 in the serum marker. That was completely new question. And there was some factual question in this area, but altogether the question paper was, I mean, this much pattern was not that tough from movement disorder and dementia. Now we'll go to epilepsy. A seizure triggering mechanism, correct match, mechanism given was decrease in release of GABA. Decrease in release of GABA. I don't know exactly what is the question asked. If that was a question, this I don't know whether it is directly from. I mean, this question I think it is more matching towards infection also. So infection also might discuss this question. So penicillin is something which triggers seizure. Penicillin, imipenem, and isoniazid. I don't have isoniazid, penicillin and imipenem. They both act in the same way, triggering seizure. They both actually are GABA antagonism. While isoniazid actually decreases pyridoxine. You know that isoniazid decreases pyridoxine. That is why we give pyridoxine when patient is taking isoniazid for TB. So pyridoxine indirectly decreases the GABA production. So the answer here is isoniazid because of the pyridoxine deficiency. All others basically act by antagonizing the GABA. The fluoroquinolones, the penicillins, imipenem, all these things antagonize GABA. The seizure mechanism is either GABA decrease or glutamate increase. Excitogenic pathway increases, inhibitory pathway decreases. So, this GABA decrease in penicillin, imipenem, fluoroquinolone occurs because the receptor antagonism. But production is decreased when you have vitamin deficiency, which is required for synthesis, like pyridoxine. So the answer there is isoniacids acid, which decrease the release of GABA because GABA production is reduced. So basically, isoniacids acid decreases pyridoxine, reduces this is wrong. Don't read it. This is some typo error. So it has been what I meant was fluoroquinolones. The fluoroquinolones, penicillin, imipenem, GABA A receptor antagonism, isoniacids acid decreases pyridoxine, reduces pyridoxal phosphate, decreases glutamine decarboxylase, and that causes decrease in GABA. So that answer there was isoniacids acid. So next question is something again we have discussed. Shepard-Ganmé sign is ictal pout, which we have discussed in the module. I kept a photo of ictal pout. This response, that ictal pout occurs in anterior cingulum as well as insula, basically a frontal lobe epilepsy. So both options are there. Inferior frontal lobe is there, insula is there, SMA is there. All these are part of frontal lobe. So somebody remember it is a symptom of frontal lobe. They had gone one extent further. This is actually a little difficult question because the option contains all our frontal lobe. If they ask frontal, parietal, temporal, it is easy. But they had kept anterior cingulate, they had kept inferior frontal lobe, they had kept insula, they had kept SMA. So among these two, it causes anterior cingulate lobe is the most common, followed by anterior insula. This is just insula is given. First, second thing is it is not the most common. Most common answer is anterior cingulate cortex. So this question I felt it is not an easy one. Somebody who has read through this sign only will be able to answer this. Otherwise, they might not have heard of this sign only, because we have discussed the same figure and details we have discussed on module. So anterior cingulate cortex is more common than anterior insula based on many of the articles. Because this is something which is a new sign, not a new sign. It was there when I remember it was like I was into my final year. I attended one of the epilepsy conference. This sign was discussed there. That was the first time we were hearing of that Shepard-Ganmé sign. So that is a ictal pout. So that was actually not an easy question. A 16-year-old female with myoclonic seizure in early morning with EEG showing forehead spike, drugs to be given. Don't make it very complicated. Just take it as a clinical scenario. Suppose a 16-year-old female come to your OPD or consulted you telling that she had seizure more in the early morning. Early morning seizures, I told, is generalized. You will think of primary generalized epilepsy, right? PGE. So primary generalized epilepsy can be childhood absence epilepsy, juvenile absence epilepsy, and juvenile myoclonic epilepsy. The age group of 16 fits more into juvenile myoclonic epilepsy. Again, myoclonic seizure never occur in childhood absence. Then J, juvenile absence epilepsy, myoclonic component is not that common. So myoclonic seizure at a 16-year-old always suspect JME. So question is very simple, JME or juvenile myoclonic epilepsy, what is the drug of choice? So phenytoin and other sodium channel like phenytoin, sometimes your uh, carbamazepine, oxcarbazepine, these all will worsen primary generalized epilepsy seizures. They worsen absence per se as well as myoclonus. I had told in the module that this should be avoided. I discussed a case also which went to status because of eptoin. So phenytoin cannot be given, that is sure. Then carbamazepine again cannot be given, so that is sure. So there are two options, valproate and lamotrigine. You all are thinking about valproate is the strongest and the best drug, but see, this is a female. So you were thinking about levetiracetam in the option. So if there is an option, levetiracetam is not there. What we have is valproate and lamotrigine in a reproductive age group female. The drug of choice is either lamotrigine or a levetiracetam. Lamotrigine is a very fantastic drug here, and especially before the advent of levetiracetam, lamotrigine was a drug which is given for a reproductive female, which again we have discussed in the module. So the treatment which is same from our module, valproate, lamotrigine, levetiracetam, particularly for female. Phenobarbital also has been tried in previous days, nowadays not used. Isolated myoclonus use combination of clobazam with valproate, levetiracetam or lamotrigine. And prognosis, usually JME requires lifelong treatment. So CAE, the age is 4 to 10. JAE, it is 7 to 16. Here to 16-year-old. So CA is out. Again, myoclonus was there. And other seizure types, myoclonus can occur in JAE, but not common. Myoclonus never occurs in childhood absence epilepsy. So age was against, myoclonus was against. So question was differentiation between JAE and JME. So frequent myoclonus is something which favors JME. Even if you are confused between JAE and JME, here the tag is here primary generalized epilepsy, you should avoid phenytoin, carbamazepine. And among valproate and lamotrigine, a female lamotrigine is the best drug. So answer is C. So that was about that. Now comes to the next question: anti-epileptic drug which has prodrug. So prodrug is something which the primary drug is not active and it is converted to a second drug which is active, that is known as prodrug, and it is conversion is through by enzymes like clopidogrel is a prodrug, while your Brilliant or your ticagrelor is not a prodrug because it's directly active agent. So oxcarbazepine, I don't know what are the options. If oxcarbazepine, it is a prodrug. It is converted in the blood to carbazepine, which is active. And phosphonatoin is a prodrug, which is converted to phenytoin. Lamotrigine, lacosamide, levetiracetam, all three are primarily active drug. They don't need a metabolism to make an active product. There are certain molecules like benzodiazepines, like clonazepam. They are converted to norclonazepam in the body, but clonazepam is not a prodrug. You have to understand that. That may comes in next year question paper or some year, we don't know, because the question patterns like they follow some pattern. Because clonazepam is converted to norclonazepam. Clonazepam is also an active drug. Norclonazepam is also active drug. So that is not a prodrug. Prodrug is when your primary drug, phosphonatoin, is not an active drug. Oxcarbazepine is not an active drug. It is converted to an active drug. So the answer is oxcarbazepine. Phosphonatoin and phenytoin divalprox, that is again it is not actually a prodrug, which is converted to a body valproate and valporic acid combination, and in GA tract it is taken to valproate, so not a prodrug, no enzymatic conversion, not a primarily inactive drug, but phosphonatoin and phenytoin is a prodrug and oxcarbazepine is a prodrug, clopidogrel is a prodrug. So that was about that. That is a CYP19 mutation is associated with clopidogrel resistance because CYP19 is required to convert clopidogrel to active metabolite. So this question I am not sure. The question is somewhat like this: a child with language issues and grimace, and which is done. So I think what they want to tell is something with epileptic encephalopathy with the language issues, because options was regarding that. Which is done. Start on steroids is MRI positive. Sleep, wake EEG. Only wake EEG will clinch the diagnosis. MRI done to know the etiology. Actually, everything is correct in a way. Because if you find something relevant to treat with a steroid in MRI, you can treat it because it can be symptomatic epilepsy, but it is not that quite common. Landau-Kleffner syndrome or LKS is an acquired auditory aphasia syndrome where you have seizures originating from the eloquent cortex, from the language area. That create aphasia like decreased communication, aphasia, mutism, and even like autism like child. And such patients, if you take the EEG, it will show spike localized in temporal lobe, left temporal lobe, and these spikes become very prominent and generalized during the sleep, which gives CSWS, continuous spike and wave during sleep. CSWS is diagnostic for LKS, which we have discussed in the module. So the EEG requires sleep plus wake EEG is required. MRI you can start on steroid, but this is not the actual answer here. Only wake EEG will clinch diagnosis. Wake EEG may not clinch diagnosis. Diagnosis is by demonstration of CSWS with temporal lobe origin and the history. MRI done to know etiology. Actually, that is true. Any seizure, we will do MRI, but in this case, if you do and diagnose, it is enough to diagnose. MRI is not required for diagnosis. So, Landau-Kleffner is a partially reversible acquired verbal auditory agnosia, seizures, and behavioral cognitive disorder, which we have discussed. All those things are in our module. You can refer to our module for further details. Basically, EEG, posterior temporal sharp waves, multifocal in NREM, which develops into CSWS, occurs at some point of illness in almost all cases. So that is something which is required. So among the following, the true statement, I think it is sleep and wake EEG should be done. So in MCQs, you have to go with which is the most probable. That's the only way to approach MCQ. So prognosis, seizure usually remit by 15 years. Language and neuropsychological symptoms have some improvement. 10 to 20% has complete normalization. So this is a status you can see the temporoparietal centrotemporal spikes originating in the left hemisphere, the language region around the eloquent cortex, You can see in the sleep, the frequency increase is going to continuous spike and wave discharges during sleep, which is diagnostic for this with history. First one is valproate, absence, ethosuximide, all those things we have discussed in detail in our module. You can go and refer to the module. Uh, Drugs which are not given in typical absence, again, this is a repeat question. The same question like you asked that one question was there regarding JME in a 16-year-old female, what is the drug of choice? So you avoid phenytoin, carbamazepine because they provoke absence or the general or even myoclonic. So drugs which is not given is eptoin should not be given, phenytoin should not be given. So the answer is A. Ethosuximide is a drug of choice for typical absence as well as valproate, and lamotrigine also can be tried, but phenytoin should never be given. Next question: 20-year-old with status epilepticus, phenobarbital was given. After 12 hours, he was not responding and absent brainstem reflex. What to be done next? So this was a question on actually brain death. Even if you are not read brain death in detail, you will be able to answer it. Just go with the question. No need to get confused. Such questions, if you are not understanding, first thing is look at the options. If you look at the option, you will understand what the questioner meant, the examiner meant about the question. The question is regarding apnea, all those things. So you cannot, you can directly tell that this question is regarding brain death from the options. The next part is, if you just see the question, she has been given phenobarbital is a sedative, which is a very strong sedation with strong respiratory failure. She might be in ventilator. So whenever a patient is in ventilator and on sedatives, you are not going to declare brain death unless it has crossed a significant T half of the drug given for sedation. So just 12 hours you cannot predict. You have to wait for the phenobarbital to wean off. Then you decide whether he is brain death or not. Because phenobarbital causes loss of brain reflexes, brainstem reflexes. It is a deep sedative. So perform apnea test is not a wise time because you are not at the drug half dose is not at over. T half is not at over. Continue supported treatment and serial neurological examination. That is what you are going to supposed to do it. If you having decreased activity of at least 48 hours, 72 hours, then you start evaluating. Withdrawal supports never. You are treating a status epilepticus. Your idea is to provoke the burst suppression pattern and maintain it at least for 48 hours. So you are not supposed to think of brain death at 12 hours. That is as simple as that. So you don't have to know everything in answering such questions. You just use your common sense. You are treating status epilepticus to get a suppression of burst suppression pattern which persists for at least 48 hours. Nuclear perfusion image, all those things are not at all required now. So the answer is continuous supportive ventilation. So we'll discuss about few things about brain death the confirmation. Prerequisites, these all should be checked. One is coma, irreversible and cause known. This patient is on phenobarbital. That causes a coma. So that is the therapeutic coma we induce. So that you cannot declare it as brain death. Neuroimaging explains coma. Sedative drug effect absent. Sedative drug effect is there. No residual effect of paralytic drug, absence of severe acid-base electrolyte abnormality or endocrine abnormality, normal or near normal temperature, blood pressure is more than 100 and no spontaneous respiration. On examination, pupillars not reactive light, typically mid-position 5 to 7, corneal reflexes absent, eyes immobile, oculocephalic reflex, your brainstem reflex are going to check, the oculovestibular reflexes, no facial grimace on pain, a gag reflex, cough reflex, no motor response to noxious stimulus in all four limbs. Apnea testing, hemodynamically stable, ventilator adjusted nomocapnea. And apnea testing, what you're going to do is you make the patient hemodynamically, the patient should be hemodynamically stable, and you give the ventilator to a normocapnia and you do ABG to see whether the PCO2 is between 35 to 45. Then you pre-oxygenate with 100% oxygen for 10 minutes. Then you also maintain oxygenation PEEP of 5 centimeter. You maintain for at least 10 minutes 100% oxygen to maintain a PaO2 more than 200. Then you disconnect the ventilator and provide oxygen during that time also via an inflation catheter to the level of carina at 6 liters of minute, or attach a T-piece. You only can attach a T-piece with a CPAP valve at 10 to 20 centimeter of O2 and resuscitation bag. After about 5 minutes, if you're not seeing any spontaneous respiration and arterial blood gas is drawn after 8 minutes. So one ABG is drawn prior, one OBG is drawn after, and which shows a PaO2 of PaCO2 of more than 60. Even if a PaCO2 is increased, it cannot trigger a respiratory drive. That is what is diagnosed of apneitis. Apneitis, I'm not going to go the details about that because in the upcoming modules we will add one module on brain death and delirium, because in last 2 years, last 1 year, there have been multiple questions on that area. So we will add a module on brain death declaration and delirium. Delirium, already we have discussed a few things in our module in residential corner. So Bradley also tells that newborn, you can repeat a investigation, and these are things which are against your brain death. And dose of propofol in status epilepticus, again I don't know what was option given, and this is a loading dose of 1 to 2 milligram per kg and maintenance of 2 to 10 milligram per hour infusion. More important thing is, this is another area which you should remember, the propofol infusion syndrome. It happens if the infusion rate is more than 4 to 5 milligram per hour, and that place only this propofol infusion syndrome happens. It basically causes bradyarrhythmia, rhabdomyolysis, and refractory shock because of mitochondrial failure, impaired fatty acid oxidation because of propofol infusion, and lactic acidosis, acute renal failure, cardiac failure with respiratory shock which occurs after propofol is known as propofol infusion syndrome. Drugs not used in Dravet syndrome, again this is something which we discussed in our primary generalized epilepsy module, epileptic encephalopathy module. So epileptic encephalopathy and primary generalized epilepsy, the two modules which for medicine students it looks like something new because this is more of pediatric cases. But in entrance point of view, these two are very important. So keep watch on those modules, because these areas as a general medicine resident you might not be that strong. So cannabidiol is approved again for Dravet. Then even tuberous sclerosis and LGS also it got approved. So cannabidiol is for LGS, Dravet, and tuberous sclerosis complex. So cannabidiol is approved for that recently. Fenfluramine again approved for Dravet and LGS. Stiripendol is an add-on for Dravet, which all those things we have discussed. Rufinamide is for LGS. All those things, all these drugs, all those things we have discussed in our module. So the answer here is rufinamide, which is only the drug of LGS or Lennox-Gastaut syndrome. Don't confuse me, LKS and LGS. LGS is Landau-Kleffner. This is LGS, that is Lennox-Gastaut syndrome. You see, in this question, there are quite good question came from primary generalized LGS, LKS spectrum, which are not actually pure medicine topics. I mean, it is more of pediatric topics. LKS and LGS, all those things are actually pediatric topics. But they can have some patients coming to adult age, but predominantly pediatric topic. So the answer is tiripendol is add-on for Dravet, cannabidiol for Dravet, LGS, and tuberous sclerosis complex. Fenfluramine is given for Dravet and LGS. So rufinamide is a drug which is given only for LGS, not in rufinamide among the options given above. So patient with epilepsy and NCCT brain is shown below and identify the hyperintense structure. So even if there is no history of seizure and all is given, this is the third ventricle, the lateral ventricle, and this is the internal capsule. This is a caudate, this is thalamus, this is lentiform nucleus. This one is clear, right? So this area is where your pineal gland will come. So this area of pineal gland cyst and pinealoma can present with focal seizures and generalized seizures. So that is one area which is now there is a lot of discussions happening recently, not now, when like since many years. So when a special patient presents seizure, if you see a pineal gland cyst, you also consider the possibility of a seizure originating from this. So that is something you should know. The next question is least common site of seizure origin. This actually you use your common sense. SMA, you know that SMA causes seizure, insula causes autonomic seizure. We discussed same previously also. One case on your Shepard granular sign, and hypothalamus can cause gelastic seizure. So the answer is caudate nucleus is a subcortical structure, which is where the seizure is not common. Seizure usually originates from cortex, also from hypothalamus. The answer is C, caudate. So that was about epilepsy. Now we will discuss about stroke and vascular neurology. So that was about discussion about epilepsy. Epilepsy, there were quite a good number of questions, and many of the questions are, unlike the moment I saw, they are not as easy for especially for MD resident, but these are many of the topics we have discussed, and these were from some other questions from epilepsy, particularly this epileptic encephalopathies, drugs in epilepsy, then seizure mechanism. I feel that question on seizure mechanism was a bit tougher one only. Uh, Probably somebody who had read about antibiotics and seizure mechanism of antibiotics will know it. Uh, Otherwise, it is not an easy question. Like so, epilepsy part was bit tougher questions. So now coming to stroke and vascular neurology, there are 7 questions. There are new questions were there, and the first question itself, I just want to keep this question. Lerock score is used in severity grading, and this is something which is relatively new. Nowadays, there have been questions coming about one question in scoring system, but there are n number of scoring system because neurology has wide variety of cases. So there can be some questions randomly coming. You cannot study all the scoring systems, names, and all. It is almost fairly impossible. So at least some common things comes you can answer if you study some of the common scoring system. So this was one scoring system which is used for IVH. There are basically two scoring systems in IVH. One is Garib system and Lerox. So Garib Lerox scoring systems. So it's again a neurosurgical topic, in fact, because practically this in practical scenario, these IVH are managed by neurosurgeons, but neurologists are not managing it nowadays. Maybe in your medical colleges or in government setups, it may be managed by neurologists, but uh, classically these are managed by neurosurgeon. So this is used for severity grading of Lerox. Just by heart it, Lerox and Grabe score. There are two scoring systems based upon the amount of blood in the ventricles. In Grab system, Garib system, uh, lateral ventricles, each lateral ventricle is scored separately and maximum score of 12. And this is scoring system. I don't think they will going to ask about scoring system and all, but just remember the name of scoring. Each ventricle is scored separately and total score is calculated. Maximum score is 16 in Lerox, it is 12 in Garib system. So these are two scoring system. So that was something, it's a bouncer, I feel. Subarachnoid hemorrhage is seen in. One of the students told me that their consultant discussed it during the rounds about the scoring system. So she could answer. So, uh, so that was, if you have heard about it, you have somewhere heard about it, you will be able to answer it. And subarachnoid system, subarachnoid hemorrhage is seen in. So, SAH, I had explained it again in the module on SAH in MCQ. SAH is divided into two types, aneurysm and non-aneurysmal for a practical purpose. Non-aneurysmal are usually in the cortical bleeds, and non-aneurysmal bleed causes, I had explained multiple times in our discussion, even I had discussed some cases of RCVS. So basically RCVS, CVT, uh, post-trauma, hemorrhagic transformation of an infarct, and metastasis. These are 5 causes for subarachnoid hemorrhage non-aneurysmal. I'll explain once again. RCVS or reversible cerebral vasoconstriction syndrome, CVT, then because of hemorrhagic transformation of an infarct. So these are 3 common causes. There are other causes like trauma is also a quite common cause, but trauma you will never miss an essay. You don't have to worry about etiology because etiology is already there in the history. Then along with that, you will also see sometimes meningeal mets, particularly hemorrhagic mets, hemorrhagic meningeal metastasis. These are the different causes for non-aneurysmal SAH or cortical SAH. So the answer is cavernous sinus thrombosis, uh, TB meningitis, ependymoma, glioblastoma. All these, especially TB meningitis, may looks like an SAH in a CT because of the large, and the T1 MRI or CT, because a large amount of exudate, proteinaceous exudate, but it is not SAH. So about true about lateral medullary syndrome. Again, it is easy question. Lateral medullary syndrome causes ipsilateral facial loss and contralateral. I don't know whether they meant weakness or numbness. I think it is contralateral sensory was what they meant, because ipsilateral facial weakness usually never occurs in lateral medullary because it is nucleus tractus solitarius is classically affected in lateral medullary, but in neurology you cannot tell anything cannot occur because there is something known as a loop of seventh nerve. The human fibers descend from the right side. Usually it reaches a pontine nucleus in the pons, facial motor nucleus in the pons, but sometimes it may goes down till medulla and goes up to same side or even crosses to opposite side. So that aberrant loops are there that can present as ipsilateral, unilateral, contralateral, human facial. I don't know what they meant is that. I felt the option given to me from the student might have some error. So I think the answer is ipsilateral facial loss and contralateral limb weakness. Uh, Contralateral facial, if you ask me, neurological point of view, whether this option A and option C are correct or not, they both can correct. Because this loop, suppose I'll draw once again. See, this is a aberrant loop which is mentioned again De Jong. Usually the cortical fibers, suppose the right side human cortical fibers, uh, descends to the pontine nucleus of facial nerve here. This is a facial motor nucleus. But sometimes it may descend down till the medulla, in the medulla, and then it will ascend either on same side, sometimes it will ascend on opposite side, sometimes they will go to the opposite or sometimes even goes to this side. So these are the upper network which occurs in 5 to 10%. Such patients can have unilateral or contralateral facial nerve. You cannot predict that. So I don't think those were what examiner meant. Examiner meant is ipsilateral facial loss with the ipsilateral, contralateral limb sensory loss. And Horner syndrome is same on the ipsilateral side, not on the contralateral side, because sympathetic fibers doesn't cross. So this is something which is very easy. You can go and check in our brainstem module 2 regarding the lateral model where I had explained all those things. Recurrent artery of Hubner. Again, this is something which we have discussed in ACA. Recurrent artery Hubner is a branch originating from ACA. And this recurrent artery originated Hubner classically originates from A2, but sometimes from other division of ACA also. This recurrent artery Hubner basically is the MCA, and this is the MCA, and this is the both internal carotid artery, and this is the ACA forms ACOM and goes upward. This is the A1 segment, this horizontal segment or A1 segment, and from the A1 segment this branch comes posteriorly and supplies as a head of caudate nucleus, anterior limb of internal capsule and putamen. So that is recurrent artery Hubner, and recurrent artery Hubner is one artery when you have an ACA disease which present with upper limb weakness or unilateral motor weakness. So whenever somebody presents a prominent motor deficit, not just lower limb, upper limb also in ACA territory, ACA vessel disease, you think of recurrent artery Hubner. Only 80%, 70-80% will have recurrent artery Hubner, but 20% or 30% will not have recurrent artery Hubner anatomically. They are anatomical variation. Basically, it's something which we discussed. It is a branch of ACA. And which of the following is true regarding tenalteplase? All are true regarding tenalteplase except tenalteplase has shorter half-life than alteplase. In fact, tenalteplase you are giving it as bolus, but alteplase you are giving it as infusion. Alteplase is given as infusion because its T half is too small so that it cannot last even for 1 hour. You want to give it as infusion so the effect should last for a long time. So tenalteplase actually has a longer half-life than your alteplase. And tenalteplase is a recombinant and it is more potent and more fibrin specific. So this is wrong and this is true. It is more resistant to tissue plasminogen activator inhibitor. True, that is why it is more efficient than alteplase theoretically. Can be given as IV bolus is true. So the wrong statement here is answer A. Tenalteplase is given as shorter half-life and tenalteplase is now being approved. Now being approved in 2026 guidelines, and even retiplase and pro-urokinase are other drugs which has been mentioned, not with complete approval. FDA approval for tenalteplase is also there. So that is why nowadays tenalteplase questions keep on coming. So that was about tenalteplase. So alteplase tissue plasminogen activator. Modified tissue plasminogen activator is tenalteplase. Administration is intravenous infusion while it is intravenous bolus, and it has longer half-life, about 20 minutes. It has about 4 minutes, very shorter half-life, and fibrin specificity is much higher. Resistance to PA1, that is plasminogen activator inhibitor, is very high for tenalteplase, and the efficiency is not inferior to alteplase. Bleeding risk is potentially lower of intracranial hemorrhage. Mortality is potentially lower mortality and lower cost in theoretically, but practical evidence also it shows non-inferiority of tenalteplase. And in my personal experience, tenalteplase I felt it is much more potent because you can save a lot of time. You can give it in a casualty itself, suddenly bolus, done, it is done. No need of continuous monitoring like alteplase, and you can take for further imaging directly soon after tenalteplase bolus for angiogram or DSA or stenting. So always tenalteplase has the advantage in stroke. Nowadays it has almost removed alteplase in practical scenarios because the ease of administration. A 15-year-old male, this is an interesting question. Sickle cell anemia present in the left hemiplegia over 6 hours of imaging showing bilateral frontal lesions in DWA That means bilateral frontal. DWA means bilateral diffusion wide image. That is bilateral frontal infarct and reciprocal changes on ADC. Angio was showing obliteration of bilateral ICA. Options for next management. This is an interesting question. So basically, this is sickle cell anemia. Just remove all those details about sickle cell anemia, all those things. Just take it as somebody came to you with stroke with 6 hours of MRI, 6 hours from onset. Will you do thrombolysis? You are not going to do thrombolysis because you have evidence up to 4.5 hours. New guidelines from 4.5 to 9 hours only if you have an automated perfusion image. So thrombolysis is never an answer, so that is out. So next question is MC M1 segment stenting. From the option, they are not mentioned anything about MCA. They are told bilateral ICA obliteration. So that is also out. So the question remaining is whether you do bilateral ICA stenting and also referral. So basically, sickle cell anemia is a cause of Moya disease. So what you are seeing here, obliteration of bilateral ICA, that is nothing but a Moya disease. So Moya has Moya syndrome and Moya disease. It's Moya syndrome. Moya disease is very idiopathic. Here, when it is secondary Moya because of other disease, radiation, and one very common cause is sickle cell anemia. So if you find Moya disease, you are not going to do any intervention other than neurosurgical bypass. The treatment is ECA ICA bypass. That is a treatment. So you need a neurosurgery referral. Is the correct answer. Bilateral stenting is never done in Moya. Moya, there are vessels are leaky. In adult Moya, bleeding risk is very high. So what you are going to do is a stenting. It's not for stenting. It will go for an extra cranial, intracranial edams or some bypass surgeries, which again we have discussed in our module, I think. So that is the answer. And again, in the new guidelines, they had mentioned about lysis and thrombectomy guidelines for children are now available. So another question is anterior cerebral artery characteristics of all except. It's actually a very easy question, MBBS level question. Gives to anterior communicating artery for collateral circulation. There is only one echo. 2 ACA joined to form one echo. So this is obviously wrong. There is no need to go in other option. But if you want to go contralateral weakness in ACA presentation, of course in contralateral correct. Present with frontal distribution sign present because ACA present predominantly with frontal lobe. ACA supplies medial frontal lobe and frontal lobe. And recurrent artery pneumor, remember it supplies caudate, anterior of internal capsule and globus pallidus internus and externus. So this is true. Frontal distribution is too commonly present lower limb monopressor, classical ACA presentation. So wrong statement is 2 echo, only 1 echo. This is like an MBBS level question. So that was about stroke. In the stroke, there are only few questions, and all the questions were reasonably good standard questions. And one question on Moya was asked indirectly, but that also you can answer because I had discussed the same thing in Moya part also. So that was about stroke. Now I'll go to neurophthal and demyelination. So now coming to neurophthal and demyelination, there are 5 questions asked, and one question is about 2024 McDonald's criteria. Those who have attempted my stage 2 preparation, I was discussing about this 2024 McDonald's criteria as well. So we will do an update soon. We will do an update and we'll come to your app also regarding 2 things. One is stroke guidelines and the McDonald's criteria, the new McDonald's criteria. So basically the question was a young female who presents retrobulbar optic neuritis, symptoms for 5 days, and she had previous history of tingling and numbness in the right arm and leg recovered by itself. An MRI T2 flare hyperemesis showing juxtacortical, periventricular and spinal cord, and CSF showed oligochronal bands. And what is the correct options in McDonald's 2024 criteria? So basically, I'll tell you that the young female presented retrobulbar optic neuritis. Previous criteria, optic neuritis was not included in 2017 McDonald's. Now the changes happened. One is inclusion of optic neuritis. 2 is new signs known as central vein sign and paramagnetic rim lesions or PRLs. 3 is a new biomarker known as CSF light chain bands. So these are the new changes, major 3 changes. One is optic neuritis is included. The central vein sign and PRLs are taken. CSF kappa light chain assay can be taken as a marker just like OCB. And the fourth is that some of the spinal lesions previously not included in active conditions has been included. And fifth, there is a criteria for diagnosing a patient with RRMS and MS consider same criteria. And last is more than 50 years, there should be some caution. Basically, the major changes is these things, and of which the patient optic neuritis. So your basically your aim of the McDonald's, whether it is 2017 or 24, it has not changed. It is dissemination in time and dissemination in space is what you are going to prove. So basically retrobulbar optic neuritis, and there's a history of numbness the right arm and right leg. So there are two spaces separated by time. So already dissemination in time, dissemination in space is met. Only thing is image. Image also shows T2 flare hypertension in juxtacortical, periventricular and spinal cord. There are again three areas. Three areas are included. There is actually this is required. This is enough to diagnose this as multiple sclerosis. So the answer is T2 flare hypertension in multiple locations with oligoplanar bands in CSF in McDonald's criteria 2024 for dissemination in time and space. So basically this is 2017 criteria. In 2017, clinical attack, MRI or OCB is what is required for dissemination in time if it has only one attack. So this patient itself has a one attack plus a clinical attack in the past in the history. But if you take 2017 criteria, the optic neuritis cannot be included as a clinical attack. So there was only one attack. That is a past history of right side MS. So it requires further evidence to classify it as MS. But in the new criteria, you take optic neuritis as a first attack. I mean present attack. And she had a one attack in the past. That means dissemination in time is met. And there are two space clinically, that is optic neuritis and the past attack. MRI wise, there are three areas. So basically, it fits into the criteria for McDonald's based on 2024 guidelines. So in the 2024, she doesn't need OCB. She can be diagnosed with the previous symptoms and current optic neuritis without any further evaluation can be included. So that is why 2024 criteria is there. I don't know what are other options. Among these options, I feel this is the best answer. And we'll do a discussion. It will take some time. It may take half an hour to discuss about the new criteria, why the new criteria came, what is the different old criteria. All those things we'll discuss in a separate module. So that was about that question. The next question is lesion to visual pathway. Which among the following is false? Macular lesion causes central scotoma. Macula is the area where the central vision is there. So that is true. Visual cortex lesion produce incongruous hemianopia. Incongruous hemianopia is a feature of optic tract lesions. That is wrong. Lesions anterior to optic chiasma cause anterior to optic chiasma, the optic nerve comes optic chiasma, optic radiations, and then it goes like this to occipital cortex. So basically, lesions anterior to optic chiasma will produce unilateral eye findings. That is also true. Cella lesion, if the lesion is cella, bilateral nasal fibers are crossing, the nasal fibers are affected, so that produces temporal field losses. So bitemporal anopia is common with cellular lesion. So those three are correct. So the wrong statement is visual cortex causing incongruous hemianopia. Incongruous hemianopia is classical as in optic tract lesions. So that is what is known as this is optic pathway, all these lesions from genicular cortex from the optic nerve till back. So this we have discussed in the module. Now the another question is from the VEP. This is an interesting lesson new that we have discussed VEP in optic nerve regarding the investigations of optic neuritis. In neurophthalm module, we have discussed about OCT and VEP. So this till this much years, this much detailed question on VEP was never came. So question is which corresponds to anterior visual pathway. That was a question. So basically, it is in EEG as well as your VEP, upward going are negative and downward going are positive. The positive is mentioned by P. So what you see at 100, P100 is at around 100 millivolt, what you are, 100 millisecond, what you are seeing a negative wave, by a positive wave, that is a P100. So there is an N75, then a P100, then at N145, which means that when you throw the light at 75 micromilliseconds, you will get a negative wave, that is a N75. You will get a P100 at around 100 milliseconds, and then you get a negative wave at 145 milliseconds. That is a normal VEP. What you are going to measure in VEP is actually P100 amplitude and latency is what is relevant. in a VEP. So yeah, P95 is a primary, P75, N75 is what is a primary visual cortex. P100 is a conduction along the optic nerve and pathway till the visual cortex, and N145 is a lateral cortical processing. So anterior visual pathway is represented by the P100. In another way, the question is very simple. Which among the wave you look for an optic neuritis in VEP? VEP is basically used to find out optic neuritis. You use P100 latency and amplitude. So it has a latency, it has an amplitude. When latency is prolonged, you call it as demyelinating optic neuritis. When amplitude is reduced, you will call it as axonal optic neuritis. That is what you are going to see. The second positive wave, that is a P100, is what is crucial in VEP. This is something which we have discussed in our pathway. Normally it's around 110. So if the latency more than 110, that means it is demyelinating. Amplitude is around 5 to 10. Basically, if amplitude less than 5 is significant. It means amplitude loss, which is seen in axonal, just like your MCA. So that is what is another question. So these two questions, both the questions are slightly updated newer questions, but we have discussed the VEP in detail in our module. So you can go there and see. So which among the following visual symptoms is not seen in optic neuritis? False regarding optic neuritis in MS, something like this question. So optic neuritis classically causes color desaturation, that is classically seen. Pulfrich phenomena is a depth perception abnormality classically seen in optic neuritis of MS. So that is true, this is true. Spontaneous recovery can occur in optic neuritis. Hemianopia, that one side loss, either bitemporal or whatever. Hemianopia is classically seen in back, like lesion from chiasma backwards. It is not what is seen in the optic nerve. The optic nerve, you will see unilateral visual loss. See, if there is a optic nerve damage here, it will cause unilateral visual loss. But if as you go posteriorly, you will see all this hemianopia. So basically, hemianopia is not a feature of optic neuritis. And Pulfrich phenomenon, again, we have discussed in the MS module. That is a symptom of MS where there is a abnormal depth perception. So MRI open ring enhancement is a feature of. I had discussed it multiple times. We have similar questions multiple times. We have discussed in the stage 2 preparation also. Open ring enhancement is classical feature of demyelination, but open ring can occur in other causes, including glioblastoma multiforme. It can occur sometimes in tuberculosis, but classically it is defined in demyelination. It can occur in malignancy as well. That is something which you have to remember. So classically, open ring enhancement is classically defined in demyelination, classically in MS or tumefactory MS. So that was about the neurophthal and demyelination. Now going to peripheral nerve and muscle and NMJ. So in the demyelination part, there are new updates asked about VEP also. There are some advanced questions. Advanced questions I felt came from epilepsy as well as from from your demyelination session. Which antibody against neurofascin protein in CDP? Again, this is something which we have discussed in our module. I had discussed in high field updates in where I discussed about CDP update and autoimmune nodopathies, it's a new entity. I discussed in detail about the treatment, what is the prognosis, what is the symptoms, what are the antibodies, nodal, paranodal and juxtaparanodal antibodies. The complication here is, you see, there is node, you have NF156 bar 140. And your paranode, you have NF155, CNT1 and Casper1. And juxtaparanode, you have Casper2 and CNT2. So in the option, you see, in the option there is both NF155 and NF156 are there. So both are neurophysin related antibodies associated with nodopathies. The question is neurophysin antibody against CDP. I've discussed in the module where I discussed about autoimmune nodopathies. I told you specifically that NF186 and gliomidin are more common with acute to subacute presentation. So they are associated with CDP, but they are more associated with acute subacute presentation or acute ADP like presentation or acute CDP like presentation. So among this, I feel one NF155, if that is the exact options given, then among this, I feel the best option is NF155 because it is severe subacute onset polyneuropathies having FSGS and retrofibrillary fibrosis. Paranodopathies which present CADP-like presentation are more common with paranodopathies. This is something which I discussed in the module. I discussed about NF150 is more common autoimmune nodopathies, NF155, young onset with distal dominant weakness and all. And then I also explained about pan-neurophysin antibody where you have this is a more severe variant. Nephrotic syndrome can occur, it is a more severe variant. So those things we have discussed. Juxtaparanodal, you have Isaac syndrome and Moravin syndrome. So that was about the answer in that was, I think, that among the options, the best option, because NF 186 and NF 155 both causes ADP like presentation, but NF 186 causes more of acute ADP or acute CDP like presentation. So the best answer should be NF 156, 155, sorry. So that was about that. So the next question, if you want further clarification, you can refer to high yield topic. I discussed about update on CDP and autoimmune neuropathies. Sensory supply of first web space in the foot. It's very easy question. It's a deep peroneal. You know that the peroneal nerve is common peroneal, deep peroneal, superficial peroneal. Superficial peroneal supplies the entire leg except the first web space. First web space is supplied by deep peroneal nerve. The next question is extensor digitorum brevis nerve supply. So all the intrinsic muscles in the dorsal of the foot is supplied by deep peroneal. So uh, extensor digitorum brevis is again supplied by deep peroneal nerve. So this is again an anatomy related question. This is something which is like usually not asked. Usually in your PG and such questions comes, but this can some questions keep doing coming like that. So true regarding LEMS. I don't know whether the exact options given is same because I have some confusion regarding the option. The LEMS or Lambert-Eaton syndrome, myasthenic syndrome, has become important, especially the differentiation with botulism, LEMS, and myasthenia has become important in entrance nowadays because in NEET as well as INET kept on asking. But I had discussed in the module as well as the last INSS also one question I discussed in detail about LEMS. LEMS is a directed antibody directed against P by Q gated voltage gated calcium channel in the presynaptic. So because the presynaptic voltage calcium channel is blocked, the calcium cannot enter into the cell and vesicles cannot be released. So when you do repeated stimulation by using high frequency, or you do a short duration brief exercise, what happens is this will activate this calcium channel and this causes release of vesicular calcium because of recurrent stimulation, calcium in the presynaptic terminal increases and that causes increased release. So it will improve. So that is known as increment in high frequency. But the option they are given is both increment in high and low, low frequency. But actually in LEMS, the low frequency it shows either normal or it can show decremental response. So I don't know why it is given like that. If that is option, that also can be correct, especially when you have a very low CMAP, very low compound motor action potentials. So LEMS, the first thing you should always check the last previous discussion on 2025 May. I had discussed about LEMS. I had discussed in detail about LEMS. You can go and check there. Also, we have discussed in the module as well. But much more details on electrophysiology I discussed in the last discussion. So basically, what happens in LEMS? The baseline CMAP is low. Baseline complex motor action potential is low. But usually in myasthenia, it will be normal. And when you do a RNS with a low frequency RNS, what happens is either a flat or a decremental response is there. The decremental response also occurs even in myasthenia. So that cannot differentiate. So post exercise or high frequency stimulation, it causes recurrent stimulation, causes the calcium accumulation in the presynaptic. Because of that, the vesicular release will improve. Because in the LEMS, the presynaptic voltage calcium is affected, so calcium is unable to entry. Now the calcium increases because of the high frequency stimulation. The vesicles get released, and the post high frequency stimulation (RNS) that is around 20 to 50 hertz, or after a brief exercise, what happens is the increment occurs, and this increment is usually more than 100%, very high increment, usually above 60%, usually above 100%. So that is a diagnostic for LEMS. So LEMS has a low baseline CMAP, low frequency RNS showing 2 to 3 hertz, decremental response maybe percent or even flat, high frequency RNS. But a caveat is sometimes it is very low CMAP. It may appear as if it is increased. I don't take it as a classical finding of LEMS. But if that is there in the option, other options are false, then you can go with that option. That is one caveat you see usually in practically in LEMS. Then another thing is botulism. Botulism is also presynaptic. Botulism where there is similar to LEMS. So you have a low CMAP, low frequency shows decrement, but the difference is high frequency it shows increment, but increment is moderate. Why? Because In botulinum toxin, unlike the LEMS, in the LEMS it is because the calcium channel. When you do a high frequency stimulation, what happens is calcium is getting accumulated here. Here in botulism, it is not because of lack of calcium entering into the presynaptic. It is because of the toxin blocking it. So even if an increased calcium comes, neurotransmitter release will be significantly affected because of toxin. So that causes some improvement, usually up to 20 to 60%, but never as high as seen in LEMS. So that is one differentiation feature of botulism from LEMS. So the stimulation, high frequency stimulation goes increment, but usually it is less than 60%. So the answer there, I think it is this. If that is the only option, I don't know what are the options there, but you should understand the concept of that. So what is Bruns-Garland syndrome? Bruns-Garland syndrome is a plexitis, lumbosacral plexitis seen in diabetic. So important thing is it is seen in type 2 diabetes. I explained in the module also. This is quite common with those with normal or near normal or well controlled diabetes, not in uncontrolled. That is one thing which is very common. This is supposed to be because of inflammatory. So that is why steroids response to pain, and some of them advocate to give IVEG as well. So it basically presents severe pain. After some time, some days, it will present wasting and weakness of the calf. So the answer is typically this. It is not seen in type 1 diabetes, it is seen in type 2 disease. It is not a form of motor neuron disease. So the answer is causes acute pain with wasting of the calf and leg. Next question is 60-year-old chronic smoker, 9 months history of fatigable weakness and lethargy. Which among the following is wrong? Again, it is fatigable weakness. That means it is again more likely to be neuromuscular and lethargy, and more important is he's a smoker. So paraneoplastic neuromuscular junction is LEMS is I think what they are meant about, but it doesn't rules out myasthenia anyway. Which among the statement is wrong? CMAP shows reduced amplitude LEMS. What happens? CMAP shows reduced true. Improvement with pyridostigmine. Again, I have some confusion in these options, but I'll come to that. RNS shows increment in both high and low frequency. Investigate to look for neoplastic etiology. So that is also true. Among these two options, I don't know what exactly is given in the options. If it is given that incremental response in both high and low frequency, that can occur quite frequently, that can occur. Especially when CMAP is too low, that is not because of the pathophysiology of LEMS, that is more because of the interpretation and the method of doing it. So that can sometimes occur, but classical increment in low frequency is not exactly correct. So the answer, the question, if it is RNS shows incremental response in both high and low frequency, I think it is wrong only for the time being, because it can take in another either way, because pyridostigmine is not the drug of choice in LEMS, but it is used as an add-on. So it shows some improvement. But if the statement is it improves with pyridostigmine, that is wrong. And if the improvement, the statement here is shows some improvement is pyridostigmine, that can occur. So it depends upon these two options. If the some improvement is not there, I will go with it can be pyridostigmine, can be wrong statement. And high and large frequency also is actually true. So I am actually confused with these two options. So I still go with option number C, because uh, improvement with pyridostigmine is not a classical feature of LEMS, but pyridostigmine can be used as add-on as well. So mild improvement can occur, but I am really confused with these two options, because I don't know what exact statement given in the question paper, because what we got is only stem of the question. So what I will tell you is, if it is among these two options, if you think uh, the last question was also regarding the same, a similar option was there and that was taken as a correct, then you should consider RNS with increment both to the high and low can be taken as correct, because that can occur sometimes, rarely in LEMS, where especially when a CMAP is too low. So I think in that way you can take it as the option is correct, is show improvement with pyridostigmine, because pyridostigmine is not the drug of choice of LEMS. The drug of choice of LEMS is actually 3,4-DAP and amphetamine. That also we have discussed in the previous session. So that was about that. This is because I don't know what exactly the options are. Either C or B, depending upon what way they had quoted it, it may be either true or false. So that was it. Then which among the following is a mimic of motor neuron disease? It's also very easy, which we discussed multiple times. Motor neuron is a pure motor syndrome. So just see which among the following is pure motor syndrome. This is a sensory motor syndrome. It doesn't have element. It is a human. PML has nothing to do with it. and PLS is a type of motor neuron disease. It is PML. PML is an infection. JC virus, nothing to do with it. So the answer is confused between MADSAM and MMN. MADSAM is sensory. Sensory is not a feature of motor neurons. So the answer is MMN. It's actually a very easy question. The most common cause of ALS, familial ALS, which we have discussed multiple times, I was telling the same thing. C9orf72 is the most common familial mutation associated with ALS. The answer is C9orf70 or of 75, 72, which we have discussed multiple times. So that was about the peripheral nerve. Peripheral nerve, there was some confusing questions because I don't know what exactly was given in the options. So there were a little bit confusing questions were there. So now coming to the miscellaneous questions. Miscellaneous questions, again, some questions on infections were there. Beta 1,3 glucan in CSF is a marker for this. I think we have discussed galactomannan and beta 1,3. Both are markers of hunger. And galactomannan is specific for aspergillus, while beta D galactan glucan, beta D glucan is a marker of a pan-fungal marker. So the answer is fungal. So these are different markers which are used in the CSF for serum. Galactomannan can be done in serum, CSF, even for the BAL, which is for aspergillus. Beta D glucan for pan-fungal. Cryptococcal antigen, you all know for cryptococcus. Indian for cryptococcus. KOH mine for hyphae and yeast. It is not yeast. And PAS and GMS strain are using histopathology for fungus and PCR. These are different fungal detection protocols which can be used. Galactomannan, beta D glucan, cryptococcal antigen, intining, KOH bond, PAS, GMS stain in histopathology and PCR. Hiranobodies, again, this is something which we have discussed in our module. While discussing ALS, I have discussed about Hiranobodies. Hiranobodies is something just classically not seen in ALS only, it is seen in Alzheimer's also. There are eosinophilic inclusion bodies, which is eosinophilic bodies which are seen in degenerative disease. So it is classically seen in ALS. Among these three, the classical degenerative neuronal disease is ALS only. PML is not a degenerative disease. MS is not a degenerative disease. FSS is a muscle disease. So it has nothing to do. So the answer is Hiranobodies in ALS is again something which we have discussed in the module. It is not a diagnostic feature of ALS because it can overlap with lot of other degenerative diseases. Droxydropa is approved in FDA for. This is something which is very straightforward. Even I don't think it is a neurology question, but it is just also hypertension approved therapy is droxydropa. Midodrine, droxydropa, even pyridostigmine is also there. Morrowen syndrome. Morrowen syndrome, you all know Morrowen syndrome is voltage gated potassium channel mediated Casper or LGA1 mediated syndrome. They present with limbic encephalitis, peripheral nerve hyperexcitability, neuromyotonia. So, VGKC, voltage gated potassium channel. I think there is the error happened here. Is VGKC. Voltage gated potassium channel. Yes. Neuromyotonia, yes. Limbic encephalitis, yes. If limbic encephalitis, sleep disorders are classical for Morrowen syndrome, and if limbic encephalitis is not there, that is Isaac syndrome, which we have discussed again in the MCQ session in our autoimmune encephalitis. So the answer is this is wrong. Morrowen syndrome usually respond well with to immunotherapy, even steroids, rituximab, IV, G-Plex, they respond well. There are a few group of refractory Morrowens which are treated with rituximab. So that is what is the treatment for Morrowen syndrome. Then coming to next question, again anatomy question. There are a few anatomy questions came from the nerve. Dorlos canal is related to abducens nerve or sixth nerve. So the answer is box. So again, straightforward knowledge based MCQ question. Lesion where pupil is pinpoint. Again, it is very easy question. MBBS level question. It is a response. Bars, cars, Morse. This barbiturates, carbamates, morphines, organophosphates, and ponds. These are the conditions where you will see a pinpoint pupil. Bars, cars, Morse, and ponds. Identify the structure. I think this was the mark structure. Okay, you can see it. This is a mark structure. I think this was a question. So, it's a caudate. This is lentiform nucleus. This is thalamus, and this is internal capsule. It is anterior limb of internal capsule is marked. So, the answer is internal capsule. Middle-aged man with a left-sided headache daily for 4 months for 1 to 2 hours, relieved with triptans, having similar episodes 9 months ago, lasted for 1 month. Choose the correct option. I don't know what are the options given. That is a confusion there. So many other I think the PG or the student who has sent to Marrow this question thought it might be a migraine question, but it's not migraine because left-sided unilateral headache for 4 months and lasts for 1 to 2 hours. Migraine usually more than 4 hours is a classical diagnostic criteria for migraine. So it is a short-lasting headache and it is unilateral. Always unilateral, left-sided unilateral headache. Unilateral short-lasting headache, always think of TAC, trigeminal autonomic cephalalgias. And it is a middle-aged man. There is a male. TAC common in male is cluster headache. And again, you see there is episodes for, he had similar episode 9 months ago, lasted for 1 month. So he had 1 month duration, one episode 9 months back. That also favors towards cluster headache. So the answer might be something related to cluster headache. I don't know what are the options given. So this is not a migraine. This is most likely to be cluster headache because the duration of pain is much less. So your other tags are there. Remember, it is lasts for 15 minutes to 180 minutes. It's the duration of cluster headache. That is around 2.5 hours. That is where the cluster headache lasts. Other trigeminal autonomic cephalalgias are suntan suna, which are very, very, very short lasting up to seconds. Then you have paroxysmal hemicarina that also lasts for 45 minutes or 1 hour, doesn't last for 2 hours like this. So that is typically for again men, and they are not mentioned about multiple episodes per day. That is one thing which is against cluster, but from the question, I think they are meant about cluster only. Uh, and uh, and cluster, and among the TAC, cluster is one headache which responds to triptans. So at least 5 attacks lasting or very severe unilateral orbital, supraorbital or temporal pain lasting for 5 to 180 minutes when untreated. At least one of the following that was not mentioned there, but among the options that I feel it is a TAC, episodic cluster headache and chronic headache. You can recheck our trigeminal autonomic cephalalgia session, which I have uh, discussed in detail about these headaches. So abortive therapy, you see triptans are there. That is where the triptans show some response in that patient. 100% oxygen. Again, this was a previous question. 2 to 15 liters at least for 20 minutes. Again, this duration was asked in the question. So, greater occipital nerve block, prednisolone therapy for transitional, followed by conversion into maintenance therapy with verapamil, diltiazem, lithium, topiramate. All these drugs are used. So, I don't know what was the options given there. So, this is a cluster, paroxysmal hemicarina and Sanct Suna and hemicarina continua. You see the duration and frequency are the most important. The duration is very low for paroxysmal hemicarina, 30 minutes, half an hour. So this is how you differentiate, and you see that this is different treatment. This all those things we have discussed in the module. So that was about the discussion on the INISS 2025. So the question paper was not that very easy paper, but there are a lot of updates asked. And unlike the previous year, there are some questions were tricky, and some of them I don't know what exactly the options were, and some questions actually were confusing for me also. And some of the new updates also, that was relatively well balanced paper, but it's not very easy paper. But okay, you can answer most of the things. So, and tough questions will be there. One or two boomerangs also, bouncers or boomerangs also will come in exams. That is what exam is meant to be. So that is about the discussion on INSS. Hope for all the best for the next coming INA in April 2026. Thank you.